Hey, good evening, everyone. Can you see us? Can you listen us?
Yes, yes, Dr. Vijayvergiya, we can see you and very clearly, sir.
Very nice. Thanks, TCT India, South Asia, for the invitation. It's a pleasure and honor for the Department of Cardiology PGI to present a live case to the meeting. And good evening to each and everyone, chairperson, and the delegates. So, let me introduce my team. Uh, I am Dr. Rajesh, Professor, Department of Cardiology. With me, Dr. Basant is there. He's Associate Professor in the department. Dr. Ganesh is a Senior Research Fellow, and Dr. Atit is the Research Fellow from the department. I do have Puneet with me, who is looking after IVAS and the FFR. So let's go ahead for the PowerPoint presentation. Dr. Ganesh, please.
Good evening from PGI Chandigarh. Our patient clinical details. This is a 65-year-old hypertensive diabetic female with non-alcoholic liver disease, post-cholecystectomy status. She presented with exertional angina from last 1 year with increasing severity and worsening with episodes of rest pain since last 1 month. Clinical examination was unremarkable. Next, please. Her baseline resting ECG showed few VPCs other than, next please. Echocardiogram showed a normal LV ejection fraction. Next, please. So diagnostic coronary angiogram was performed, which is showing extensive calcification in the LM LAD and diffuse LM LAD 70% stenosis with mid LAD tight stenosis of 80% seen in epicranial view. Next, please. RC has mild disease and her LV angiogram was showing normal ejection fraction. Next, please. So plan for today is PCF LM LAD crossover stenting, provisional single stent strategy to begin with, plaque modification of the calcified lesion, and finally imaging guided PCA optimization.
So this is the case, and this is the angiogram in the AP caudal view. You can very well appreciate a dense speckle of calcification extending. Can you run the first view, please? Extending from the left main to mid LAD. Next view, please. It's the mid LAD till the mid LAD. Next, please. This is the spider view. Ostial L6 seems to be okay with no significant disease. Next view. Just okay, stop. So this is the case. Stop. So this is the case. Left main to LAD disease, which is calcified and the significant one, and the plan is to have no provisional stenting. So opinion of the chairperson, how should we proceed further?
We can't hear you.
I would pass it on to the panelists, and I think it's Dr. Mahesh, I think, who's there.
Sir, I would like to image the circumflex ostium, confirm that it's actually disease-free and it is safe to go in for the one-stent strategy. Then I would like to image the circa LAD to see how bad or how good the lesions are going to be, and then decide on plaque modification depending on what these two findings are.
Very nice. So here, any comment about say simple versus complex, left main bifurcation and need for say 2 versus single stent SD?
I think Dr. Sridhar Kasturi, yourself.
Yeah, actually, the lesion length is short, less than 5 mm, limited to ostium, and mainly left main to LAD, very long lesion, calcified. It's considered simple, though complex lesion. The L6 wise, it's not very significant. Better, it would be preferable to do the IVS and see the plaque burden. What is the plaque burden more than 55%, or the another luminal area also see is it less than 3.5 square mm. If that is there, I would prefer to go. But based upon the criteria, a short limited to ostium less than 5 mm, this comes under criteria for provisional stenting of LM to LAD. Post procedure, if there is an LCX pinching is there, then I would do FFR. If the FFR positive, go with the T-tap technique. Or instantly go with the simple hissing balloon. Hissing balloon, if the lesion is good flow, no need to intervene. If there's some still residual lesion is there, some dissection, flow limitation is there, to go with the T-taps.
So Gary, while Dr. Vijayvergiya was doing imaging, would you, for the purpose of giving your pearls of experience and wisdom to the audience, tell us exactly what do you want to see on imaging in this left main? And or what are the criteria that you would say this is that we should be doing a provisional here?
Okay, so let's start with wiring both the circumflex and the LAD, imaging from both the circumflex and the LAD to the left main, and the LAD pullback should go into the aorta with the guiding catheter disengaged. So let's start with the circumflex first. You want to see how much disease is present at the ostium of the circumflex. You want to know the lumen area and the plaque burden. Then your pullback from the LAD to the left
Gary,
main.
how much plaque burden? What's your...
Okay, so it's...
can you specify that?
Sure. 4 square millimeters lumen, 50% plaque burden. Those are the cutoffs. If you have less than 50% plaque burden and a lumen area more than 4, it was actually 3.5 and 50% in the paper, but for easy to remember purposes, 50% and 4, then the likelihood of jailing the circumflex and having an FFR less than 0.8 after single stent crossover is very low.
Okay.
And so you protect the circumflex, and then you stent from the LAD to the left main. Now on the LAD pullback, your questions are distal landing zone in the LAD, where is it and how big is it? What's happening at the ostium of the LAD, how much plaque there is, how much calcium. Does the plaque extend back to the left main, and if so, does it extend into the ostium of the left main? Because if the ostium of the left main is minimally or not diseased, you don't really have to cover the aortoosteal junction, and you just find a proximal landing zone. So you've got distal landing zone, proximal landing zone, which gives you the length. Your LAD landing zone gives you the stent size, and your left main size landing zone gives you the pot balloon size.
And you then see the structure of the plaque as well and decide whether you want to
Correct.
get a plaque modification. Okay,
Very
that's
nice.
great. And so Rakesh, Rajesh, you...
Yes. Go to the next view, please. Next view.
So show yours.
So
And also continue to work along with it. So I know you have less time, so you should... just
no, it's go ahead.
give
Most
your
of the
progress
as the session was delayed, I done most of the work. So let's go ahead. This is the IVUS across the left circumflex. Can you run the run of the left circumflex? So
And
this,
I would like you all to note, the audience to note, that he's actually got his guiding out and a wire in the sinus, which therefore he wants to image the ostia. I think that's an important
absolutely
aspect,
right.
Rajesh.
Absolutely right.
So
So
this
he-
is what Gary was saying.
Here
See
is
the
the run
ostia.
across the LCX. You see it's disease free. We are reaching to the ostium, and this is the ostia. Left main is somewhat calcified and also disease. It's less than 180 degree of the left main calcification. Left main size is 5. Ostium is relatively disease free, and an area which we could measure at the ostium of the LCX, the tightest point, turned out to be 5.67. So this is very much suggestive, as Dr. Gary has commented about any area which is say more than 3.9 or 4 is the one which can be left, and one can go ahead for the
Absolutely.
provisional stenting. So and then we next view please. So before that, back we did the FFR as well across the LCX. Can you show the FFR? Can you display the FFR? Yes, it's there. So
Yeah.
we had
My
now-
only comment is that, and once you have a lumen area of that size in the circumflex, the likelihood of having an abnormal FFR is
absolutely right. So what we did, we first did the FFR followed by IVUS,
Right.
just to have an idea about. So FFR turned out to be say 0.96, post intracoronary adenosine turned out to be 0.89, and thereafter we did the IVUS across the ostial LCX, which had an area of 5.67. So the plan is to go ahead for provisional stenting left main to LAD. Next view, please.
What is the length of the left main? The length of the left main. You have a port problem.
So did you mean your IVUS catheter did not cross the LED? Is that what you're saying? Okay. So you've done a rotational atherectomy. Is that what you're saying? Okay. So while you're going to run the IVUS, but just one comment I'd like to make, and that again getting Gary into it. Gary, we discussed the measurements of the circumflex when we say that this is adequate and we don't need to involve the ostia of the circumflex into a stent as 4 square millimeters. I actually have a philosophy around this and say, we said that it has to be, if we implant a stent, then the ostia of the circumflex has to be 5, ostia of the LAD has to be 6, polygon of confluence has to be more than 7, and left main has got to be more than 8, at least for the Asia Pacific region, and you can add on, but it's got to be that as minimum, anything above. And if we don't implant a stent, therefore de novo ostias need to be 1 square millimeters less, which means 4 for the circumflex, 5 for the LAD, to say we now don't need to implant a stent. Is that correct?
So I think you have to differentiate between deciding whether to treat and deciding how to treat. So if you're deciding whether or not to treat, then you really should rely on FFR or physiology, period. At least, except for the left main, in which I think imaging is probably as good or better. But I don't really care what the lumen area is in the LAD and the circumflex. If physiology is above the ischemic threshold, leave it alone. It's a little different if you are saying, well, I have a lesion that I have to stent. Do I use 1 or 2 stents? Can I stent from the left main into the circumflex and leave the LAD alone? Can I stent from the left main to the LAD and leave the circumflex alone? Those are different situations, because whether or not you want to admit it, you are affecting the non-stented vessel.
So can you run the IVUS again from the beginning? So after having a rota and also the balloon dilatation with 3 millimeter NC, we had the IVUS done across the LAD. Can you? Okay. So this is the IVUS. Calcification is 270 degree. Length, of course, is big enough, more than 5 millimeter. A indication to go out for the ablation therapy. And at particular point in the proximal part of the LAD, the area is too less. It's how much? 1.9. It's a 1.9. So this possibly is the point where the area of the LAD, despite having the rota and also the 3 millimeter NC balloon dilatation, the area turned out to be 1.9 millimeter square. Next. Next view. Okay. So now question arises, after rota and also with the NC balloon, we had a calcified lesion, 270 degree arc, length of course is there, rota ablated the thing to great extent. What next? Is it IVUL or cutting balloon?
Rajesh, I think we are running slightly behind. Can you show us what have you done till now?
Fine. So let's go ahead. There was a need to further dilate the LAD, whether it's a cutting balloon or IVL therapy. So I choose to go ahead for, say, 3.5 millimeter cutting balloon across. It's a 3 millimeter Wolverine cutting balloon from the Boston, with which I had dilated the LAD and also the left main. Next view, please. So this is what I had in a dissection at the ostium of the LAD, which is extending to the left main as well. L6 is okay. Next view, please. Next view, please. So this is 3 into 33 giants across the mid LAD. Next view, please. Next view, please. Next view, please. As the proximal LAD was 3.5, left main is 5. I put a drug-eluting stent 3.5 across the left main to LAD. Regarding the choice of stent, which can be very well discussed, here I did put a synergy stent 3.524 from left main to LAD. Next view, please. Next. So this is the result across the left coronary system. Next. The wire across the L6 was changed. Next. Port was done with a 5. Next. This is the 3 millimeter NC across the mid LAD. Next. 3.5 across the proximal LAD. Next. Next, please. Good flow across the LAD. Next. LCX has some pinching, whether it needs the intervention or not can be discussed very well. Next. I dilated it with 2.5 millimeter balloon just to open up the struct across. Next. This is the ostial LCX. Next. So here we are after doing all the things. So now the plan is to have the final IVS across the LAD. As I had dilated with 2.5 across the LCX, a repeat kissing balloon has not been done across the left main. And IVS imaging has to be done across left main to LAD to look for what the result is after having a balloon dilatation with 3 in the mid part, 3.5 proximal and 5 port.
The only thing, Rajesh, I didn't see you do is after the, to do a kissing as the last step of your balloon dilatation of the side branch, which is the circumflex.
Yes. No, I have not done. I am just waiting to go live. To this point, I had done the procedure, and now I am proceeding further.
Thank you. Thank you.
So meanwhile, you can go ahead and discuss, and let me have the IVS catheter across left main to LAD.
My suggestion is that you do your kissing and then do a final IVS and then optimize the LED as you need.
Okay. So now the question is...
It's not going to achieve you anything more apart from, we'd rather see your final results. So just go ahead, do your kissing, and then do your final IVS.
So here the query is whether there is a need to have a kissing. We say 2.5 balloon across the LCX and 3.5 across the LAD, or should I go ahead with the port across the left main only without having a balloon across the LCX? Though angiography LCX ostium seems to be significant, but we can very well go ahead do the FFR and if required IVS as well across the ostium and the LCX to decide about any further dilatation across the ostium. So meanwhile, let me go ahead for the IVS across left main to LAD, and this point can be very well discussed.
My clear, and again I go to Mahesh, who's sitting there, because I think we'll soon. Srinivas, we have 2 minutes to see his final results.
So then let me go ahead for the IVS across.
So Mahesh, Srinivas, do we have 2 minutes or do we?
Actually, time is over. Just check with him.
Okay, I think one comment which is very important out here, and that's to understand, and I think Mahesh come in and Gary. See, when we dilate the circumflex with a 2.5, we are going to move that main branch stent away from the other side. So it's actually a mandatory. The moment you actually start to decide doing a side branch dilatation, the final is kissed. That happened in EBC main. That has happened in every other point. So for a two-stent strategy, it is a final endpoint. For a single stent strategy where you dilate a side branch, it becomes a final endpoint that the main branch has to be dilated, either a kissing or pot side pot. So I just want to understand from Mahesh and Gary, and then we can just shift off to see the next point which Srinivas guys. Okay.
So meanwhile, here is the IVUS across left main to LAD. You can carry on, discuss, and have a look on the IVUS as well.
So Mahesh?
There is no argument about the kissing in from the left main to the circumflex in the lady. That chapter is actually forgotten, and there's no doubts about it. My only thing was you should do an IVUS into the circumflex in this case, because when the dissection came from the left main, from the LAD to the left main, I thought that the ostium of the circumflex may also have been involved in that process. That's what I was a little worried about. But you had a good flow, and probably the FFR, you may do an OCT into the circumflex to see how the ostium is.
So, Dr. Gary, any comment about, say, FFR or IVUS across the jailed LCX to look for a significance of it?
Well, I think the circumflex will look, or can look, like it's gotten a lot worse. But if you do FFR across it, it's never abnormal.
Okay.
And the reason is because you really don't get plaque shift. You get deformation of the carina, and it's extraordinarily short. And the circumflex is the artery that least commonly has an abnormal FFR anyway. If you're worried that you had an ostial LAD dissection and that it turned down the circumflex, there's nothing wrong with gently putting an IVUS or OCT catheter into the circumflex, but you have to be cautious because they don't always behave well going through the stent struts.
Very nice. So here is the run from left main to the LAD, and then we are out. Let me remove the catheter. Meanwhile, you can very well discuss the finding of the, can you run the IVUS run? And then just let me know about what next to be done for the LAD. And meanwhile, let me try to push my IVUS catheter across the LCX as well.
Yeah, I think we would soon have to move, Rajesh. But
Okay.
you could tell us that I would just suggest that we would actually have a kissing. You have to optimize the LAD. It is invariable that the struts would move away from the LAD opposite wall to where you dilated into the circumflex.
Fine.
Circumflex FFR would be negative, however pinched it may look. And you've yourself actually shown a tremendous case around this, even in the past. And I think that you would end up with making sure
So
you're
let me have a run across the LCX in case I am able to push the catheter across, and then
I think, sir, your final comments, and we'll break here. Because
so here we are IVUS.
We should just have Navisundi's final picture.
So this is the IVUS across the LCX.
You can just tell us. You do just tell us what the IVUS shows.
Okay. So IVUS is fine across the proximal LCX.
Okay.
Let's go ahead for the ostium. Ostium, it's there is no dissection across the ostial LCX. And left main, as we have already seen for the left main to LAD, I can very well have the dilatation with the pot 5.
So my
and let me
final
review
comments on this are that I think it is good to see a layered provisional strategy. And I think this has been a very nice illustration of a layered provisional strategy with good imaging to optimize the situation.
Namaste. I'm Dr. Srinivas Kumar, Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. This video brings best wishes and greetings from FACS Foundation and TCT India South Asia 2021. In this video, we would like to bring to you the live case learnings of an interesting case of left main and ostial LAD and proximal LAD disease, calcific vessels, effectively managed by IVUS guided left main to LAD crossover PCI. This was done by Professor Rajesh Vijayvergiya from PGH Chandigarh. What we have studied and learned in this live case transmission is how to assess the severity of stenosis of left main and then osteal LAD and the proximal LAD disease, and how to assess the calcium presence in these vessels by intravascular ultrasound. And what we have learned is whenever we are doing intravascular ultrasound, the HDIOS, probably the calcium assessment is there, and if it is there all around, all through, here we had about 270 degrees of calcium. It was effectively tackled by initially superficial calcium was also there, tackled by rotablation, followed by opium balloon inflation. Then the mid-LED stent placement was done, and then it was also decided to do a crossover stenting from left main to the proximal portion of the mid-LED stent by selecting the proper size by intravascular ultrasound guidance. The other important aspect which was discussed and effectively communicated by Dr. Gary Meads, who is an imaging expert, is the criteria for assessment of severity of stenosis in intravascular ultrasound. What he mentioned was whenever the osteal LAD had a stenosis area of less than 4, generally it would be important, or the plaque burden of more than 50% again. In left mains, we all know that we consider areas important if it is less than 5.7 or 5.9 in various studies, again with a plaque burden extending more than 50%. This was highlighted. Another important aspect which Dr. Seth was mentioning was the criteria for success of post-procedure. Like after we've done a successful stenting, what the criteria we initially thought as 5, 6, 7, 8. Again, for Caucasians and for Indians, probably you could add 1 more. And the more bigger the values, you get the better outcomes on follow-up. The minimum was 5 for LCX ostium, 6 for LAD ostium, 7 for confluence, and 8 for left main. And if you get a more higher value, so it is better. These are the minimum what we need to achieve. And Dr. Seth was also mentioning if you decrease these values by less than 1 mm, probably you could consider those lesions as important. But what Dr. Gary Meads felt was rather than area, we should rely totally on the physiological assessment of the severity of the vessels, especially in this chronic coronary syndrome calcific vessels, because that's what is decides rather than exact areas. And he always stressed that physiological assessment should take a priority over deciding the severity or significance of the lesions, be it proximal or any other place. Whereas if you have to decide regarding what strategy should use for a PCI, whether to do a crossover or whether to do a 2-stent technique, or such decision should be taken on the imaging basis. This is again very important point which was highlighted and mentioned by Dr. Gary Meads. What we found in this case was LCX was free from ostium, was free from disease. Left main was having significant stenosis, and then osteal of LAD was having critical stenosis. The tightest point was just 1.7. Area came as 1.7 square mm. Then again, mid-segment had significant calcific disease. This was initially tackled by rotablation, followed by opium balloon preparations. IVAS was again done to assess the cracks in the calcium and how the area improved. Later, final stent was deployed again in the mid-segment and then proximally from left main to LAD with crossover to LCX. Immediately after the stenting crossovering is done, especially the LCX ostium looks pinched in the lower caudal view. We are always puzzled, and minimal dilatation again was done through L6 ostium, and then gentle inflation of L6 ostium was done, and the lesion was assessed by FFR. Dr. Gary said that you should always rely more on the physiological assessment of stenosis or so-called pinching appearance in LCX when you do crossover, because what he felt was it is actually the coronal shift which produces such appearance rather than real stenosis of the vessel. So however bad it may look on the angiogram, by and large the FFRs of this pinched appearances of LCX would come negative, and that's how the patient won't have problems, and they behave well in the long term follow-up. So thus we've learned how to tackle this significantly diseased calcific vessel from left main with ostial LED and medial LED disease by using the technology of bed preparation and IVAS guidance, how we can do PCIs with good final outcomes. It was very well demonstrated. I hope all of you have learned this crossover stenting technique from left main to LED through this case. And IVAS guidance played an important role to see stent expansion, position, and also to know when to intervene and how to intervene. With this, I now thank you all. Yours, Dr. A. Srinivas Kumar. Thank you.